outdoorsy stuff to do. I'm like,
Yeah.
yeah. I'm an indoor cat.
Yeah. Yeah, it's driving me nuts though. I'm ready for it to be over. So
I hear
You
that.
know, but your state's under a super lockdown. Your governor's like, no fun
yeah.
for anybody.
Yeah, pretty much.
Let's see who's joining us.
I like your Amanita muscaria ornament, Desi.
Yeah, that's from the Netherlands.
Is it? I think you brought that into a meeting once, right? And showed it?
Yeah, I did for my psychedelic show and tell.
Yeah, that's super cool. It's cool that it's from the Netherlands too.
Or Copenhagen or somewhere, I forget where my friend was on vacation. Wherever, there's those kind of Nordic culture where it's a big deal. So we might have we got one Oklahoma State alumni here. Oh, there's Dr. Ebo. You're muted.
Video's not showing. Oh,
There you are.
oh, the kid does calls, and so I gotta make sure everything is like turned off before I like get into the meeting to make sure everything's going. Hello. Let me get my headphones. Thanks for inviting me to do this.
Yeah. Zainab's here.
Hi.
Hi.
Are you waiting for some more folks to get on?
No, I was just waiting for you to get on. That's all right.
Do you want me to get us started on Facebook, Desi?
Please.
Okay, cool. I will do that now, and I will let you know. Oh, what the heck?
I like your glasses.
Thank you. It's called getting old. I was like, I need what now?
It's like you're swerving on the street, like hitting cars and stuff, doing that.
No, I have my vision's 20/20, but I have astigmatisms. Yeah. So that's the problem. Things are blurry, and I gotta focus all hard. And they're like, get these glasses so you don't have to focus so hard.
Yeah. I'm a psychologist. I'm supposed to focus. What are you talking about? How's it going, Andrew?
Weird. I'm gonna start over.
All right.
Sorry. I don't know if like Facebook is freezing. Oh, it just did something.
Your eyes got really big. What's going on?
Okay. I don't. Okay.
Oh, there it is. I see it.
Great. Sorry, I don't know if
gosh.
it's my connection or what, but it's just being real weird over here.
Oh, okay. Well, thank you, Andrew, for setting everything up.
No problem.
Being the techie.
Okay, we are good.
You're muted.
Oh,
Oh, is he
we couldn't
talking?
hear you.
Can you hear me?
Now we can.
All right. So it's like live from Denver, or live from Zoom. It's Psychedelic Club of Denver. My name's Dr. Desmond Wallington. I'm on the executive board of Psychedelic Club of Denver. I want to welcome everybody. Today we'll be talking about trauma, resilience, and psychedelics. And joining me is kind of in a conversation style will be my colleague and fellow Oklahoma State University alumni, Go Pokes, Dr. Ebony Jackson from San Antonio. I'm a psychologist in my real life too, when I'm not doing a psychedelic club, which is like 85% of my day. You know, I often get messages from different colleagues. They're like, we see you working on the decriminalized stuff in Denver, we're in Psychedelic Club. And, you know, at first everyone thought I was kind of goofy or gone off the professional deep end, you know, kind of going into the psychedelic realm as like mental health treatment and becoming an advocate for it. And slowly, you know, as like 60 Minutes and like New York Times and all these big media outlets are doing stories about the benefits of it, I'm starting to get like messages from like people I went to school with. Well, tell me more about the psychedelic therapy. Like, I keep seeing it everywhere. Blah, blah, blah. And you know, Ebony, like me, is always on the forefront of thought, always pushing the boundaries of, you know, where the profession needs to go. And you know, she's been messaging me lately about psychedelic assisted therapy and what that means. And so I thought it would be good to do like a conversation style, since instead of me just sitting here lecturing. So I'll let her introduce herself, what she does, and yada yada yada.
Hello. My name is Desi. I call him Desi emphatically, and he calls me Ebo. As you can see on there, it's Dr. Ebo. But I'm Ebony Jackson. I am a licensed psychologist in San Antonio, Texas, and primarily I am a clinician. So I provide treatment services either via therapy or I provide testing services as well as forensic psychological testing services. And so I am a practitioner at heart. Part of my training, you know, I have learned how to be a researcher as well and a good consumer of good research. And so a lot of Dr. Wallington and I's discussion has been about the good research that's out there and the not so good stuff that's out there. And so my one to speak with him is because I trust him in his credibility and understanding that knowing what junk science is versus not good science. And so I want to know more about what is the good stuff out there and not just the junk.
Good. And since you do all that testing and evaluation, why don't you, since I'll be doing a lot of speaking, let's let you do some speaking up front and talk to people about when you diagnose people with post-traumatic stress disorder or acute stress disorder, what are you looking for? What are those symptoms? And also explain a little bit about historical trauma too.
Right. Okay. So trauma is a buzzword I notice a lot these days. And so I separate what the general public sees as trauma versus what we see as trauma clinically as clinicians. You can have horrible things happen to you or around you or be exposed to things and it not necessarily be trauma in the clinical sense. When we see bad stuff happen or experience bad things, naturally we're going to have reactions to that. And so things I talk to people about when I see them, like, you've been through this horrific experience, or you saw something, or you actually heard, because the new diagnostic criteria is if people like us have been exposed to very detailed stories of someone else's traumatic experience, that in turn can cause you to have PTSD or acute distress. And so what do I mean by these clinical terms? So trauma in a sense is, it could be through your own personal experience, or like I said, a very detailed exposure to that. And it could be anywhere from a physical violence, Sometimes we consider, like thinking about domestic violence situation, a trauma doesn't have to happen at one particular time. It could be exposure over time. So when we look at historical trauma that people of color experience in this country and throughout the world, it's not just this one thing. Like we repeatedly are getting beat over the head with the same stuff, the same horrific things over and over and over again. And it continues to affect you and people from generations to come. I mean, think about the impact that, you know, colonization has had on so many people. Think about the impact that enslavement has had on people. Think about the impact that people being driven out of their own homelands has had on them and their offspring. And so when we talk about historical generational trauma, those are the things that we're talking about repeatedly. You can't seem to get up a leg up. And, you know, resilience comes along with that. You know, people have learned how to live with it and live through it and continually to live through it, even though you might be repeatedly exposed to things. And so acute distress is like right after something happens. So you may not be able to sleep well. You may not be able to think straight. Some people have a hard time, even like they feel numb. Honestly, sometimes people just feel numb and they don't know what to think or feel about the situation. You might be more tired and worn out after something happens. And if that kind of stuff, you might have flashbacks when we talk about like where you actually feel like you're in that situation again. You may have nightmares. Nightmares is common. Could be about the event or events that happen, or it could be about something completely different. You're just having restless sleep. And so when those things happen for a period of time and it lasts at least 6 months, then we start looking at the realm of PTSD, post-traumatic stress disorder. You'll have changes in your mood. Sometimes people are more irritable. Some people will feel more sad. Like I said, numb. The other thing is that you might have a shorter fuse. A lot of people who experience PTSD have rages sometimes, and that can in turn lead to other issues like substance abuse and substance dependence. So short-term acute distress, if you're looking past 6 months, we start thinking about more post-traumatic stress disorder. And again, when bad stuff happens, people react, and that's a normal thing to have happen to you. It's just when those things affect you for a period of time is when you start looking at diagnosis.
Yeah, and it's a good point. And when we think about, like you said, on the individual level, there's, trauma, acute stress disorder. And if it, lingers on for a certain amount of time period, it becomes post-traumatic stress disorder. And, that's within the individual. And, when we talk about historic trauma, we start to think about how the individual is part of a community, so like, people of color who are oftentimes, marginalized in, regions of a city, so that becomes kind of the norm, of the individual, having a stress reaction to everything that's hypervigilant and maybe exaggerated, more than what you would see in a person who didn't have those experiences. And that becomes, the community's response, to stress and, disorder. And if you think about that from the eyes of a child and a parent, that's what normalizes, those types of stressful reactions, and that becomes the norm. And those, can continue on, into the next generation, that, this is just how people react when they're under stress or when they're upset or when they're sad. And this is, what culturally happens. And, that becomes, a learned response. And, even if you dig a little bit deeper beyond what's learned, there's an interesting new area called, epigenetics, right? And that came about, post-Holocaust. They, noticed that men who survived, the concentration camps and who went on to father children, that those children had higher rates of anxiety than you would find in a normal population. So, when they talk about the normal population, they think about like a sample size of 100 people. Out of 100 people, you'd expect maybe like 2 to 5% to have some sort of anxiety disorder. And, you know, they found that men who survived and their offspring, those offspring had, you know, an anxiety disorder rate that was beyond the 2 to 5% that you would expect to find in a normal population. So then, you know, the working theory was, you know, there was something that happened, you know, physiologically that changed the genetic makeup of these Holocaust survivors that is somehow impacting, you know, their offspring. So, you know, scientists being scientists, they try to look into this, you know, how do you explain this? So they, you know, thinking of one experiment with rabbits, and they, you know, did the classic Pavlovian conditioning with the rabbit, you know, put it in a cage, expose it to the aroma of cherry blossoms. And as it was being exposed to that smell, they were shocking the rabbit. So there was a learned response between the odor and the anxiety from the shocking. And so, you know, they did that, taught the rabbits that response. And then they, you know, had the rabbits reproduce, and those offspring, you know, separated the parent and pups immediately after birth. And, you know, the next generation of rabbits had an anxiety reaction to the aroma of cherry blossoms, something that should have been at least neutral, or a, you know, positive rewarding smell was producing an anxiety response. And that response continued in, you know, into the next generation of rabbits up to 3 cycles. So, you know, it lingers in their DNA for a little while before it stops becoming adaptive again and starts to fade out. So, you know, as this pandemic has been happening, you know, I think we've all been kind of going and experiencing a collective trauma on some level. You know, you turn the news on day in, day out, and it just kind of takes its toll on you. You know, that secondary trauma, like Ebony was talking about, that's trauma that you don't experience, but trauma you hear about secondhand. About a year and a half ago, I had a friend make local Denver news. He fell down a trash chute at the apartment complex, and when he landed in the trash can dumpster, he triggered the trash compactor. And it, you know, and I was telling my friend about, you know, the physical trauma my other friend was going through. And I got a phone call from a friend that I told about this the next day. He's like, man, I just couldn't get that story out of my head. You know, it just kept playing in my head over and over again. And, you know, and so we hear these stories on the news, and it sometimes, for some whatever reason, one will stick with us and, you know, really start to wear us down emotionally and psychologically. So, you know, as like I said before, I'm on the executive board of Psychedelic Club of Denver, and I noticed, you know, when I start posting all these, I do the social media Facebook page for the group. So I post the articles, and there's, you know, articles about trauma and psychedelics, and, you know, sometimes I'll put a meme up, and people, I could just tell people are like, oh, I could, you know, I want to self-medicate myself with psychedelics. You know, there's some kind of, I can't, I'm stuck in my house, you know, I want to leave, you know, the space physically, because it does kind of wear you down being in the same room or apartment or house, you know, for weeks upon weeks. And it's just, you know, kind of interesting too, because Denver's decriminalized psilocybin, and, you know, the general public confuses decriminalization with legalization. You know the difference between the two, right, Ebony?
Yeah, basically like how when they first made pot, weed legal in some places, where you just wouldn't get prosecuted if you had some, but you could have it for personal use.
Yeah. So yeah, decriminalization is you can have it on your body and you're not gonna, you know, throw you in jail. Legalization is, you know, there's stores and dispensaries where you can go and get it. And, you know, there's always, every now and again, I get like a message, like, where do I find a therapist to do this? And I'm like, you know, I have to respond, no, this isn't where we are yet, you know, as far as a medicine. you know, psychedelics as being medicine, that, you know, there isn't, you know, these clinics you can go to, you know, that in Denver where a therapist is going to sit with you, give you, you know, 5 grams of psilocybin and just kind of watch you, you know, and hold your hand through it and, you know, have a therapy session with you. That's not a thing yet, much to my chagrin. So what's your, where are you at? What's your knowledge base about psychedelic assisted therapy? What do you think it is as a therapist? And what was your reaction when you first heard about it?
When I first heard about it, it reminded me of the 60s, because this is not the first go around with this. Psychology has tried this before.
Yeah.
I mean, this is not new. Some of these these psychedelics that came about because they were used for treatment. But then, you know, the whole, DARE and all these programs came through and just kind of pushed all that stuff out. But now I'm starting to read up more about things that like ketamine and things are starting to be used for depression. And so these things are starting to have a reemergence. And so clearly there must be some benefit. I mean, there's always going to be risk, okay? I'd have to take prescriptions. They have risk on there. Everything has risk, but there's also benefits to certain things. So I'll admit, like when I first was watching you on Facebook, I'm like, what is he doing? But then as I start to see the research come out about this, and I'm in several therapist groups via social media, there's a call to have therapists, you know, get involved in this brand new whole research study that they want to do now to see the effectiveness of this treatment approach. I'm seeing stuff about helping kind of, you know, when we talk about, we know as clinicians that trauma rewires your brain, and that, you know, psychedelics can be used to assist in rewiring it back to somewhat normal, so you're not always hypervigilant. And so that's kind of as much as I know right now about it, is just kind of rewiring the brain to treat, you know, those long-lasting body keeps the score issues that we talk about with trauma, how, you know, we just can't always fix it with talk therapy or pharmaceuticals.
Mm-hmm. Yeah, so you're right. So, you know, up into the 50s and 60s, there was, you know, a lot of research being done specifically on LSD. Sandoz Pharmaceuticals was producing it, and they called it Desilid, DYSELID, and they also, you know, were working on psilocybin, which they were calling indocybin, which was a, you know, combination of the word Indian because of the Mazatec Indians in Mexico, and the word psilocybin that Albert Hoffman coined. And, you know, before psilocybin, we didn't know that serotonin was in our brains. You know, when they, in late 57, when Life magazine did the Seeking the Magic Mushroom piece, Gordon Wasson sent a sample of the magic mushrooms to Albert Hoffman, who analyzed it. And, you know, if you look at the chemical structure with the little hexagons and the little squiggly lines coming off of it, they discovered that the active ingredient psilocybin was almost identical to serotonin, which was a scientific breakthrough at the time because they only knew about serotonin in our digestive system. You know, they had no idea that it was played a role in our brain and the neurochemistry up there. And, you know, also during this time, there was the government program, the MK Ultra, you know, the CIA was doing. And they were, you know, just going through LSD by, you know, the gallons. And, you know, and they had to order it all from Sandoz, you know, out in the middle of it's Switzerland, or, you know, wherever it is over there in Europe. And so finally, you know, they didn't want them to know how much they were using. So they, you know, paid Purdue Pharmaceuticals in my home state of Indiana to, you know, break the chemical, the bootleg the chemical, you know, LSD. And, you know, that was Eli Lilly that did that. And Eli Lilly went on to produce Prozac. So they used that knowledge from, you know, LSD to go on to manufacture Prozac. And there would be no serotonin-based psychotropic medication without that knowledge that came from psilocybin mushrooms. And then, you know, the 60s was happening and there was a big protest movement, and LSD started getting like a bad reputation because of, you know, the hippies and the counterculture. And eventually Sandoz just started slowly pulling back the research on everything. And as they were doing this, Congress was passing stricter and stricter FDA rules, because in the late 1950s, early 1960s, there was a drug called thalumide. And that drug, they would give pregnant women to help manage their morning sickness and nausea from pregnancy. And that was a company called, oh, it doesn't matter, but, and what they would find was that the children of the women who'd used this drug were being born with underdeveloped limbs. And, you know, so like missing arms and legs and that type of stuff. And it took a lot of reigning, you know, FDA really didn't have that much control over the pharmaceutical market like it did now. So that really kind of emboldened them to, you know, stricter and stricter regulations. And so why this thalumide thing is important is because as they were passing stricter laws, people would start to abuse amphetamines like diet pills and barbiturates. You know, and Marilyn Monroe was dying and everything, and they were doing news exposés where scientists or people would, reporters would order like hundreds of pills, you know, bootlegged pills, you know, barbiturates and stuff, and things were always happening in the media, like the celebrities dying, and there were a lot of truck drivers having accidents because they were, you know, abusing diet pills and stuff to stay up and drive. And so as Sandoz was, so they made, you know, bootlegging drugs illegal, but Sandoz eventually let their patent go. So anyone could, you know, make LSD, and they weren't violating a patent, and it was totally legal, you know, to produce LSD. And so California and Nevada were the first two states to criminalize, you know, possession and manufacture of, you know, psychedelic drugs. And then so like a couple guys from the Grateful Dead that were making it for Ken Kinsey, they had to flee California and come to Colorado. In Denver, they lived across the street from the Denver Zoo. You know, they were running this big, you know, LSD manufacturing site. And in May of 1968, Colorado became the third state to decriminalize psychedelics, which is kind of interesting because we were the first city to decriminalize, you know, after 50 years later. And part of the, and then later that year in 1968, there was a federal law passed by Thomas Dodd, who was a senator from Connecticut. His son is Chris Dodd, who was in, you know, did the Dodd-Frank Act, you know, after the stock market crash back then in the early 2000s. And the reason they criminalized it in 1968 was there was a doctor named Cecil Jacobson, and he was a fertility doctor. And his claim to fame as an expert fertility was once he claimed he had he impregnated a male baboon. And there was never any evidence to this. There was, you know, he never documented his methodology, and he said he aborted the fetus at some point, but that was his claim to fame before all this. And so Thomas Dodd, he was a really awful guy. I could go into how awful he is, but I won't. But he brought him up on stage or on to testify in front of Congress, and this guy said that he knew it for a fact that LSD was causing women who had used it during their pregnancy to be born with underdeveloped limbs. So it kind of tied back into that thalidomide, scare, in the late 60s. And this was all kind of coming from the fact that LSD is a derivative of ergot, which is, historically been a hallucinogenic that's plagued humankind for, thousands of years. Ergot is a mold that grows on wheat plants, and it can become airborne when it becomes really bad. And, sometimes it'll get in bread and stuff. And usually those hallucinations that ergot causes, like hell and negative trips and all these kind of negative experiences. And with extreme ergot poisoning, though, it would cause people's extremities, like their toes and fingers, to become black and to kind of like frostbite. But it wasn't frostbite, but it was just from the ergot poisoning. And they had to, cut the leg off and cut the arm off before, it got to the torso and killed the person. And they called that St. Anthony's fire. So, there was a scientific line of thinking there that ergot, LSD, like the thalidomide, and the babies being, born with the deformities, that was in line. And there was like one plausible doctor who said that this might be an explanation, but we need more clinical data, more clinical information. And I think it's Hans Zellweger, if I remember. He has a genetic disease named after him. But this Cecil Jacobson guy went on on the stand and basically lied and said, oh yeah, this for sure causes it. So, it played into that scare. They made it illegal. And interestingly enough, this Cecil Jacobson guy went on to become he got arrested in the late 80s for using his own semen to artificially inseminate his patients without their knowledge. There was like he got his own made-for-TV movie. John Goodman played him in an SNL skit one time. So this guy, who's poor clinical doctor, awful clinical doctor, has wrote our psychedelics. He's the one that derailed all the psychedelic research, that should have been happening. And, we're falling off behind. And, as you were saying, trauma affects our brain. Earlier I was talking about how it affects, the social learning theory and, the epigenetics. But, there's trauma also affects the developing brain. When we're, from the time we're conceived until the age of 25, our brains are in a constant, neurological development, right? And I did my pre-doctoral internship up in Standing Rock at the, Indian reservation in North Dakota. But my primary placement was in Charles Hall Youth Services, which was a group foster care home. And, they were one of the test sites for a psychiatrist named Dr. Bruce Perry. He developed, the neurosequential model of trauma. And what his thinking was, whenever the individual experiences trauma, it disrupts the neurological development of the myelinization. So myelinization's right when the plastic kind of coating goes onto your neurons in your brain, and it causes them to fire more efficiently and effectively. And that's why, like a 2-year-old, they're getting to that part of the brain where it's being myelinized, and they're not exactly there yet. So their walking is all weird, and their gait is all wide and funky looking when you see a 2-year-old try to walk. And as their brain develops, those neurons are firing better and more efficiently. So, their steps are smoother when they move. And so what happens is when trauma happens, your brain gets flooded with all these stress hormones. And if you think of the myelinization, like you're putting like a waxing a basketball floor with like one of those things with a big brush on it, and trauma is like the quarter, you know, on, or the penny on the floor that kind of slowly becomes a part of the floor as it gets covered in wax. And you know, that's why it's so impacts children so negatively, is because, you know, they're developing neurologically, and all that kind of stress and everything just kind of makes it, you know, self wired into their neurological wiring. And so, you know, you kind of have to think about, you know, the age in which person experiences their trauma, you know, right? So the younger the person, the less resilient they are, you know, the less coping skills they have. And you know, so, you know, that's why sometimes, you know, teenagers will turn to drugs and alcohol when their brain's still developing. And there's still, like you said, all that stigma about dare and stuff. And, you know, so psychedelics have really kind of had the negative connotation because they kind of get lumped in the same realm as like alcohol, or reverse in alcohol, you know, like heroin and crack and, you know, PCP and everything. And so, you know, if you think about the individual's trauma, the age that they experience trauma is one thing. And another kind of neurological aspect of trauma is thinking about it from the perspective of memory, right? So we have a memory, and memory is a very fallible construct, you know. So say I'm sitting here right now and I have a memory of something that happened 10 years ago, just play through my head randomly, and it's a bad memory. Since it's the first time it's playing in my head, it's like the Blu-ray copy playing in my head, the most accurate depiction of that experience. And as I play it and it runs through my head, it gets recoded into my head. So what kind of happens is like an Instagram filter kind of gets burned into that. And it's like, I'm using a lot of mixed metaphors here, but it's like, you know, back in the day when I'd get a new CD, I'd burn a copy, give you that burned a copy, and then you would burn a copy of that CD for your friend, and they would burn a copy of that burned copy, and each burned copy of that CD gets a little bit more distorted and doesn't sound as good as my original copy did, you know, each new copy that's being made. And memories work on that same kind of construct to some regard. And so, you know, the more you recall a memory, the more you're altering it to your thoughts and feelings that you're experiencing in that moment. And it becomes more distorted. And you're either remembering it towards like a trauma narrative lens, like, oh my gosh, that was the worst awful thing that's ever happened to me, la la la. So the next time I play it, that extra layer of trauma gets transposed onto it, and it just becomes, it can become debilitating, you know, the more I recall it. And but on the flip side, there's, you know, the resilience aspect, you know, people who practice forgiveness, not necessarily, that's not reconciliation where you trust your person, the person that hurt you, but you just say, you know, I'm letting that go. They're a flawed person who's had bad things happen to them, hurt people, you know, that type of thing. But I'm going to, you know, strive to be better and stronger and learn from this. In that narrative, you know, if you work on that kind of thinking every time that trauma plays through your head, you're distorting your memory towards a more healthy, resilient narrative. And so I think, you know, what happens neurologically with psychedelics, it's kind of like, you know, you go and you talk to a therapist, you know, right now, the drug that they're using for post-traumatic stress disorder is MDMA, you know, ecstasy, you know, the kind of the party drug that, you know, you kind of associate with club kids taking right at the clubs, you know, and ravers all night type thing. But it's, you know, those are often laced with other drugs. So it's, you know, the more pure form of that. And what happens is you go to, you know, psychedelic assisted therapy, and it's like a protocol type treatment that you work, you know, if you kind of identify the trauma with your therapist. I'm like, hey, Dr. Ebo, this happened, and la la la. And then you're like, okay, well, let's work on this treatment plan for you. And, you know, I'm going to teach you some coping skills for, you know, psychedelics, you know, how to do some breathing exercise, how to relax yourself in case you start to notice some kind of negative experience from the drug in session. It's good to know how to basically relax yourself and to kind of take some deep breaths and kind of roll with it, you know, pardon my pun. And, you know, we discussed the different, like I said, the trauma in detail. And then like 5 or 6 sessions into it, there's like a several hour session where I come and I ingest the MDMA, and I lay down on this couch and I put the blindfold on. If you've seen that Anderson Cooper thing on 60 Minutes, and you're there holding my hand, and, you know, I have like headphones on, you know, playing music, and, you know, and I just kind of had that psychedelic experience. And if I, you know, usually there's a co-therapist in case you have to go to the bathroom during this, they can kind of tag in and sit there. And, you know, if there's something that comes up that I need to talk to you about in that moment, you're there to talk and discuss. And then, you know, the drug wears off, you know, you make sure I get home safely. And then, you know, there's a couple post-treatment sessions, you know, as they call it, integration, where it's kind of like, how am I taking what I had experienced during that MDMA session and bringing that into my new post-psychedelic experience. So I'll kind of give an example, personal example. So as you remember, my PhD dissertation was on forgiveness, right?
Mm-hmm.
And
Your book about it.
yeah, I did write a book and and a dissertation. And so grad school hack. So anyone out there who's thinking going to grad school or in grad school, you make every single paper you write about in grad school your dissertation topic, right? So all my professors were reading about forgiveness for, you know, 3 or 4 years, you know, while I was working on this dissertation. You know, I talk about it from social psychology, I talk about it from neurological, I talk about it from, you know, any human development, whatever the class was, I'd, you know, focus that paper that was due at the end of the semester on forgiveness. So when I was working on my dissertation, I could pull it, you know, from it. And grad school is when I discovered psychedelics. You know, I knew about them from undergrad, but almost got an opportunity in undergrad to try psychedelics and didn't pan out. So my first experience wasn't until grad school. And, you know, this wasn't a part of our training, psychedelic assisted therapy. We didn't know nothing about it. I remember Barb Perlozzi telling us, our intro to counseling professor, like, you can't do psychotherapy with anyone under the influence. If they come to session drunk, session's over. You know, if they're under any type of substance, game over, you know, see you next week. So the idea that psychedelics could be therapeutic never entered my mind as a grad school. I was just doing it recreational one time. And so, you know, I one time took I don't remember how many mushrooms I ate, but, you know, I was, whatever the person sold me, I ate them and had an experience. And I discovered, oh my gosh, this is therapeutic. Like, I thought it was just going to be fun recreation, like, woo, you know, I didn't know really what was going to happen. And it was one of those kind of therapeutic moments where you know, it caused me to kind of examine, you know, like my own childhood trauma. You know, my both my parents had chronic pain, you know, and they both abused opioids, and you know, opioids did not make them nice, pleasant people, you know, to be around. You know, that a lot of holidays and special events were often derailed because of, you know, their drug use and opiate use. And you know, because of that, I've always kind of shied away from addictions therapy or addictions, you know, treatment. And it's kind of interesting that the more I try to avoid it, the more I get drawn into it with this psychedelic assisted therapy, because that's one of the treatments that they're looking at it for, is, you know, helping people with opioid addiction, psilocybin, but iboga and ibogaine. It kind of looks like a lemon, an orange lemon, if you ever see it. And it really helps people with like addicted to heroin and Oxycontin and those types of drugs. So, but back to my moment, and I just had this kind of like aha moment, because, you know, I was studying forgiveness. I understood it on a cognitive level, right? You know, sometimes you can understand something cognitively, but there's kind of this emotional gap where your feelings aren't really quite there. And after that experience with the mushrooms, all that information I had acquired and studied about forgiveness really fell into place. And I was really kind of, you know, to look at my parents and kind of reflect on their childhood experience, and, you know, think about like that historical trauma, because I know, being an American Indian myself, you know, talking minority and minority, how that trauma just sticks with you, you know, generation in, generation out. And, you know, my mom grew up in poverty, and her mom, you know, her grandma died when my grandma was 3 years old. You know, she had her in third grade, she had to leave third grade and help raise her younger siblings. So, you know, had no formal education beyond that. So, you know, you start to kind of reflect on this, and it all just kind of made sense in my head. So to kind of tie it back to the analogy I was using before, the burning of the CD and the CD and the CD, it was kind of like someone had taken that CD and remastered it, you know, like, and put it in Technicolor and made it, you know, high definition, and just really kind of magnified everything. So it really wasn't this distorted burned CD that I had been reburning for years upon years. It was this new, awesome, you know, better copy of my life experience that kind of got burned, you know, during that psychedelic experience. Are you picking up what I'm laying down? What's your reaction?
Are you talking to me? I'm sorry.
Mm-hmm.
Yeah. So it's kind of, it has the like opposite effect. It helps you build resilience.
Yeah.
It helps
Yeah.
you, kind of plugs the holes where you weren't able to do it yourself because there was this block psychologically or whatever that you couldn't get past. Because when we're people, we're always trying to label something. Like, even if you say you don't like labels, we still try to label something.
Yeah. Exactly. And, you know, my other research at Oklahoma State was on American Indian enculturation. And, you know, we asked about the use of Indian medicine, you know, like peyote, ayahuasca, you know, is this a part of your culture? Because our research is, you know, the more tied you are to your tradition, your culture, are you attending Indian church, do you eat Indian food, you know, do you consult your elders, you know, that type of stuff. And the more resilience individuals are, that, you know, they have lower rates of alcoholism, lower rates of depression, and all those things, that negative stereotypes kind of associated with being an American Indian are there. And it is a part of, you know, there's even now talking about looking at the epigenetic effects potentially of psychedelics on our DNA, and does this psychedelic experience help to undo that epigenetic trauma that happens. There's a guy named Antonio Insera who's doing his researches on epigenetics and ayahuasca. He has an article out from like 2018. And so, you know, it's kind of potentially healing on, you know, the personal level. And you think about that, you know, on an epigenetic level. So like, you know, if I had all this epigenetic trauma in my DNA and I experience a psychedelic session with ayahuasca potentially, that my offspring won't be at that epigenetic predisposition to have that, you know, epigenetic trauma response. You know, like we were talking about with the rabbits and the Holocaust survivors, everything, which is, you know, really interesting, you know, to think about. But again, you know, this is kind of theoretical early on in the research. You know, everything's got to be studied. Does that make sense to you?
Mm-hmm. Yeah.
All right. So also so as you remember in grad school, when we evaluate, okay, so the thing about this psychedelic assisted therapy, it'll be the first time the FDA has ever given its seal of approval to type of psychotherapy, which is, wow, you know, pretty
I know, what?
pretty groundbreaking, right?
Yeah.
And, you know, and sometimes it's misleading when you read the news articles, because it'll be like FDA will looking to approve MDMA and psilocybin. And so when I first saw that, I was like, oh, that means I'm just going to be able to go to my local Walgreens and pick up some psilocybin, and they're going to, you know, give me a prescription. You know, that was kind of when I first read about it, that was my takeaway. And no, that unfortunately that's not, you know, what that means. It means that it'll be like in control 3 or 4, I forget the classification, but you go in with a therapist, they administer it in a clinical supervised setting, and you're just not out willy-nilly using it, you know, yourself. You know, it's kind of like us as psychologists are the medicine men, you know, of the tribal days, right? You know, they would go to their tribal, you know, shamans, which are our modern day therapists, I guess, right? And there's a structure and the routine of the ritual of everything. And so when, you know, as we think about the research, remember there's efficacy versus effectiveness, right? When you do clinical research as to like types of psychotherapy. So first, you know, if I develop a type of psychotherapy, first step in that research is doing an efficacy study, right? Where I take a small sample of people, you know, 10 or 12, in a very controlled clinical environment, in a very structured regimen, you know, of manualized treatment. And if my form of psychotherapy works better than placebo, you know, or some other kind of, you know, neutral stimulation that shouldn't foster growth in that person, and people report less distress than the other group, my treatment, I can say it has efficacy, right? You remember that from remember that trauma of those comps, right? And then, you know, so beyond efficacy, so those efficacy studies, they have really high internal validity and low external validity, because everything's happening in the lab, cold treatment. And so it's internally true in these sterile conditions, but we don't know how that's going to play out in the real world. You know, the higher the internal reliability, the lower the external reliability. And then external validity, rather. And going on, you do an effectiveness study where you take hundreds of thousands of people across, you know, the the country, different groups, different, you know, backgrounds, as diverse population as you can get. And you do and see how the treatment works in the real world outside the cold clinical setting. And that has a high external validity and low internal, you know, validity. So as you think about, you know, psychedelic assisted therapy, you kind of have to think about it from that clinical model of a therapeutic, you know, how are they evaluating it from that regards? Because like I said, this is the first time FDA is, you know, doing any type of endorsement of the psychotherapy. In regards to pharmaceutical FDA process, it's a pretty similar method. There's a phase 0 where they, you know, dose rats in small doses to see, does it kill the rat? You know, is the rat surviving, you know, that type of stuff. So if it's not toxic, it goes on to the phase 1, and that's the safety phase where they give, you know, phase 1A is they give someone a teeny tiny microdose. How does that affect the person, you know, physically, anything negative? And then they do phase 1B where they kind of do several microdoses, and they, you know, kind of monitor how's it affecting them physically, and then they, you know, look at the urine sample to kind of see how the drug is being metabolized and processed, you know, by the body. And then, you know, once you get through that phase, they go to phase 2, and that's kind of the efficacy stage, like the clinical research, where it's, you know, they do these really small sample sizes of, you know, like 12 people, and, you know, how does it work versus, you know, so with the MDMA, you know, these 12 people with post-traumatic stress, what's their outcome like compared to people who just got the placebo? And, you know, MDMA's made it through that phase, and then there's like a phase 2B where they kind of work and refine the dosing a little bit more before they go to phase 3, which is where they kind of take it in bigger sample sizes, like I said, 300 to 3,000 people, you know, kind of throughout the country. So, you know, there's these very small handful of people who's getting to try this experiment in these very controlled settings right now. And last week, the multidisciplinary, I'm butchering the name, MAPS of something psychedelic science, and they just reported that, what's my saying? Okay, there was a third party data monitoring committee, and they had found a 90% chance or greater possibility that the trial will detect a statistically significant result when all participants have been treated. And, you know, FDA in 2017 deemed MDMA a breakthrough treatment as far as post-traumatic stress disorder, which, you know, like, breakthrough treatment is like, wow, you know, bells and whistles, that's a big deal. And, you know, especially because post-traumatic stress disorder can be very difficult to treat, right?
It's really hard to treat. And then the people who are treated often have to go back. It's kind of like a Band-Aid. The stuff that's out there now that we're doing, a lot of the CBT we're doing is Band-Aids, because people end up having to go back eventually to treatment.
Mm-hmm. So that's the where it stands right now. So, you know, if you're kind of, and then, you know, when it goes on to stage 4, that's when it becomes more readily available to people, and they do more monitoring of how does it interact with other drugs. You know, if you're, you know, taking this, because in the phase 3 you're only on MDMA, you can't be on any other type of drug because they're just monitoring the effects of that. And then they start to stage 4, how does it affect and interact with other drugs, and what are the effects it has on like pregnant women and other kind of vulnerable groups, you know, that would traditionally be weeded out during those earlier stages. I'm hearing the howling, so it must be 8 o'clock here. So we got about half an hour. And so, you know, that's one of the interesting things happening now in Oregon within this past week, they handed in all their petition signatures for IP 34, which will be a ballot initiative in that state to allow any psychotherapist who's been trained in psychedelic assisted therapy to engage in psychedelic assisted therapy, in these kind of licensed clinical sites. So, if you run a site, you can, sign up with the state, get your license, and people can come in for this manualized treatment style. And that is, and so right now that's MDMA will probably be clear the goal in 2021 and could go into stage 4 in 2022, and that's a mandatory 2-year phase of treatment for that stage. They have to kind of monitor it for 2 years to make sure that everything is on the up and up, and then it gets like that official FDA seal of approval. And then psilocybin is about a year behind that, and that's for treatment-resistant depression. So right, and that was designated breakthrough status by the FDA, which there are just some people who have that kind of dysthymic Eeyore syndrome, like Winnie the Pooh, just like, oh, well, they're just kind of naturally depressed, and they're starting to have really positive effects with that. So what's your reaction to what I just said?
I think it's promising because I think about all the people that I've worked with who've been suffering for so long. My primary job is working with people with severe mental illness. And so to have some breakthrough treatments for them is promising to me. They don't have to be on all these medications. Maybe they don't have to be in the hospital for prolonged periods of time. If they have the right kind of treatment, then they can stay out and live very productive, normal lives.
Mm-hmm. Yeah, and that's one of the things too that they've really, in the research, is if you've had any risk for some kind of psychotic disorder, like a history of schizophrenia in your family, that they exclude you from the study.
And that makes sense.
Mm-hmm.
That makes sense. I mean, even with weed, if you have a history or family history of psychotic disorders, you're more inclined to maybe hallucinate when you smoke weed.
Yeah, and there was a guy in the 60s. His name was Stanley Groff, and he did do a different type of approach. He wasn't an American psychedelic assisted therapist. He was kind of European in his approach, and he did come to the States at one point. But his methodology was he would do more microdosing, smaller amounts of LSD with his patients who had schizotypal or schizophrenia type things or disorders, psychotic disorders, and he would do a more long-term, like psychodynamic type of therapy, Freudian style therapy with them, versus the kind of the big macro dose that you would traditionally get in the what they're looking at now. And he was a little bit out there, and I think he's kind of been redeemed by history, because he would have his patients kind of go through a rebirthing process and imagine themselves being even conceived and gestating in their mom's womb, and going through the birthing experience as a infant, neonate. And and as I learned about Dr. Perry's neurosequential modeling and how trauma kind of gets wired into our brains, at different moments in our life, his approach kind of makes sense to me on a clinically intuitive level. You know, I don't have any way to prove this, you know, with research, but his modality seems to dovetail well with Dr. Perry's, you know, neurosequential modeling, that, you know, you have the person kind of reimagine these traumas and the events from their childhood, and that helps to kind of undo that stress that was helping them, you know, mentally. And, you know, there's a term that they called, you know, neurogenesis, right? Where you start to kind of redevelop neurons that were, you know, kind of pruned away as the development happened. And, you know, there might be something to that, you know, gets more studied as the clinical work continues on. Something interesting that I notice when I do the Psychedelic Club of Denver's Facebook page is, you know, in the past month or two, there's been like an article that came out about the scientists are developing a type of psilocybin that takes out the bad trip. You know, so sometimes people have these, what, you know, what's traditionally called a bad trip, right? You take some mushrooms and you start, and you think the walls are melting and you're dying, and it's like something like very hellish that happens, you know, on a subjective level. And, you know, people have kind of reframed that term, you know, bad trip, to like difficult experience. And there was a survey that Johns Hopkins did in 2017, where they surveyed 2,000 people who reported having a bad trip. And about 50% of the 2,000 people said that even though it was a negative experience when it happened, as time went forward and they kind of integrated that experience into their day-to-day life, that they were glad that they had it, that it kind of helped them to push through that trauma that had always just kind of been underneath the surface of what was going on. And again, you know, that's pretty good stats, right? 50%, right? And I noticed though that people get really angry about this. You know, they're developing a drug that gets rid of the negative trip. People are, you know, that's the medicine. That's, you know, what's supposed to happen. If it happens, you know, just what, you know, pull yourself up by your bootstraps and just, you know, go through it, man. And, you know, there might be something to that, you know, but again, that's an anecdotal response. And, you know, the way that science works is we don't know. Maybe it might be a necessary, you know, component of the treatment is having a difficult experience. But, you know, if they develop something that's produces only positive trips, you know, the experience I had with forgiveness with my mom, it was a very positive trip experience for me. It was very ethereal, very, you know, heavenly experience. I was York Vespertine album, if you're ever on Psychedelics, that's the album to listen to. And, you know, there's a couple songs that just, even when I hear them now, they trigger that feeling from me, from that experience. And, you know, and that's the fun of the science, is scientists, you know, they don't, is that Tino? You know, scientists don't let their values bleeding into it. You know,
I had to mute me for a second because he's whining. Sorry.
And she's got the cutest little dog. Pull him up. Oh, there he is. Oh, Chino. All right. But, you know, people have very, like I said, kind of lots of oughts. They ought not be messing with my mushrooms. They ought not, blah, blah, blah. But, you know, that's just kind of how science works. You know, it's a value neutral endeavor. You can't, you know, let your biases bleeding into your research. It could be a question, you know, they could develop this drug, test it against the traditional, you know, type of mushroom that could produce a negative trip, and this stats will tell us one way or the other when we get there. But, you know, in the meantime, it is just kind of a, like I said, this has been on the pause for the past 50 years, since 1968, when they federally outlawed, psychedelics. And my brain is running at an end. I think I've hit every talking point I wanted to hit. What are your questions, thoughts, Ebo?
So I know one thing that you and I have talked about is the people that are like the therapists or psychotherapists, I should say, who they're going to have involved in this. And something that had come up is not every place that you are, every state has a different definition of what that means. And I had no idea that in Colorado, one can call oneself a psychotherapist with no training whatsoever. And I admit that's concerning. If I want to go see a practitioner and I want to have, some psychedelic assisted therapy, I want to know this person is at least trained in that aspect. If I do have I don't want to say bad trip, we say an unpleasant experience, I want somebody who can actually help me through that's trained to do that. Rather, is whatever breathing mechanism I need to learn in order to help me calm down or to process it after the fact. I want to know that I'm in good hands, basically. And so that is a little concerning to me if people aren't adequately trained in order to provide this assisted therapy.
Yeah, and that I remember, learning about that too, before I knew about psychedelic assisted therapy when I first moved down here as a psychologist. I was working at this agency, and they were like, "When can you come start working?" And I was like, "Well, my license is still being transferred from Oklahoma to Colorado, and it should be here next month." And I'm like, "Then once it gets here, I can start working." And they're like, "Oh." They're like, "You don't need your license. What are you talking about? This is, the wild, wild west of Colorado. You can just call yourself a registered psychotherapist, and, there you are." And I was like, "What?" And she's like, "I know, it's very weird, but, there are these people." And on some level, it makes sense because it is kind of like people who are like a life coach, I would put it, people who, if you're kind of a high functioning person who just needs not a lot of deep psychological work, but just maybe some, positive skills and that type of stuff. Cool, awesome. But sometimes they go beyond the scope
When we
of their
talk about
practice.
trauma work,
Yeah.
like that's really thick work, and you can really stumble around if you don't know what you're doing.
Yeah, and that is something that is an issue in the realm of these kind of underground psychotherapists, is that, sometimes people will go to them and they will do things, use substance, Schedule 1 drugs, like some type of psychedelic medicine, and people end up sexually assaulted, by their therapist. And it's, even people who sometimes have a good reputation end up being predators. And that's the scary thing when there is no licensure person being overseen,
There's
that
no oversight.
Yeah, that you really open yourself up, especially if you're a woman, doing this work, or, trying this treatment, that you're in a more vulnerable spot than maybe a man would be. And that is scary. And, that's kind of what makes this kind of, as this is becoming more legitimized and more of a thing, there's going to be more therapists are going to set those boundaries with these registered psychotherapists more firmly. And, you can't use certain terms, unless you're a psychologist or a counselor, that, if you only have a bachelor's degree, you can use some terms. Like in Oklahoma, you can be a behavioral health rehab specialist. And when you write your notes, you can only talk about, we talked about behaviors and coaching and that type of stuff. And if you're an LPC or a master's level person, you can say, we processed emotions and feelings, but a behavioral rehab specialist can't write that down in their notes because they're not trained to do that. and an LPC can't do a psychological exam because they don't have a doctorate in psychology or a PhD in psychology. And, you know, so they can only use the word psychology, you know, and we can't use the word psychiatric, you know, exam, you know, when we do evaluations. So, you know, every niche has their own kind of parameters of what terms and words they can use. And right now there is kind of a free for all, you know, in the psychedelic realm, just because it's so underground by nature, that as this becomes more prevalent, I guess those people will kind of get squeezed out to the fringes.
I mean, and think about where this comes from. I mean, we talked about indigenous
Yeah.
peoples have been doing these things for centuries.
Yeah.
People from my motherland in Africa. I mean, we have our healers, we have our shamans, we have been using mind-altering substances therapeutically for centuries. So it's not new. It's not always some trained clinician that's overseen by a board, but I think it's important to have some kind of oversight so people aren't being harmed.
Mm-hmm. Yeah, you know, exactly. You know, our friend Glenna Stumbling Bear, right? She's Native American Kiowa tribe, and her tribe, you know, has a really strong history with peyote, you know, in their treatment. And, you know, there's a big push to, you know, preserve that sacred medicine for indigenous people, and to, you know, for non-indigenous people to use mescaline or San Pedro or another type of, you know, cactus that has that, but just to save peyote for that tribe. And, you know, her tribe was a major part of psychedelic history. You know, in the early 30s, they let the father of ethnobotany, Richard Schultes, he came from Harvard, all the way from Harvard to, you know, Bumfuck, Oklahoma, to, you know, observe their, you know, peyote ceremony. And he also went down to Mexico and was one of the first to discover the psychedelic magic mushrooms down there. And he's the one that told Gordon Wasson, the guy that did the Life magazine, Seeking the Magic Mushroom in the 1950s, about, oh yeah, that's where the mushrooms are, go down to that tribe, blah, blah, blah. So, you know, it's kind of a small world of psychedelic, you know, medicines right now. And as this research is growing and clinicians like you become more interested in it, you know, there's going to be more of a, I don't, professionals are going to start to try to hone in and try to seek out that turf, I guess, more, I guess. Seen it. So again, what time do we got? Okay, we got about 10 minutes. Any questions from the audience? Hey.
Hi, great talk, thank you. I'm wondering what either of you know around approaches for addressing birth trauma. So, you know, trauma that you experience as part of your birth story rather than inherited, right? Like a difficult birth. I'm wondering what your thinking is on that or what you know about it. Oh.
You're muted again.
All right. So I'll kind of go back to that, my Dr. Bruce Perry training about the neurosequential modeling. So when I worked at Charles Hall Youth Services, you know, the group foster care home in North Dakota, you know, they would do these very intensive evaluations. You know, was this a wanted pregnancy? You know, how much stress was the mom in during, you know, the pregnancy? You know, did she have all the nutrition and, you know, the prenatal vitamins and everything that she needed? Because if those conditions weren't met, that was either neglect happening in the womb or stress. Anytime the mom experiences stress, you know, the baby gets flooded with those stress hormones as well. And so, you know, oftentimes to kind of get to those areas of the brain to help, you know, heal that type of stuff. That was like when the kinetic stuff would come in.
Hmm.
You know, the like not physical therapy. What's the other one?
Somatic?
Not some. Yeah, somatic.
Occupational or
Occupational therapy. That's it.
Occupational therapy. Yeah.
Yeah, and you know that, and they
define
find something
motor
that's
skills.
work on those motor skills. That those target those areas of the brain that were being neglected or abused or stressed. At that phase of neurological development. Like I said, with the penny being engraved into the basketball floor and that trauma just kind of being molded into your brain.
Mm-hmm.
So sometimes kids would be into karate, which is, very refined, movement and stress and learning deep breathing and retaining, and using the least amount of force possible to accomplish a goal. Or swimming was a big one too, because that soothing feeling of being in water.
Yeah.
And kind of that movement and everything. So that's kind of when you think about the younger the brain was when it experienced, you try to find stimulation that's going to nurture that area of the brain. Does that get at what you're asking?
Yeah. I'm wondering what's the intersection with the thinking on psychedelics in assisting. Do you go after some sort of also kinetic experience?
I don't know too much about it, and I don't think the research knows about it, but I
Yeah.
really, again, kind of fall back on that Stanlock, it's DeGroff, Dr.
Stan
Groff.
Groff, yeah.
His thinking of having the person reimagine their birth and their experience, and as that neuroplasticity and neurogenesis, I can't speak, that the brain, the neurons are growing again. As that is happening, and as you're kind of reimagining it, maybe that's kind of helping to nurture that that trauma that happened.
Trying to rewrite it, rewrite it at a low level.
Yeah. And again, because like I'm saying, if memory is just that photocopy of a photocopy of a photocopy that you're always manipulating anyway. So if you're just focusing on that one period of time in your life and rewriting that, you get that Blu-ray copy back again, or everything's in high def and pristine copy.
Thank you. Yeah.
All right, one more question. All right, maybe not. People are like, we're tired of you talking, Desi. Well, I want to thank Dr. Ebony Jackson for
Thank you for inviting me. I learned a lot, and I'm proud of you.
Well, Dr. Ebony was just, I'm going to brag on her for a minute now. Dr. Ebony Jackson was just on her local news. As this COVID stuff's been happening, there's been, people having to wear masks in public spaces. And there was a gentleman in San Antonio who kind of went off the charts at a local grocery store or something. And, they turned to her for her expert advice. So, I'm proud of you, and you're venturing out there and getting your face out in the crowd. And I'm glad I could invite you. I love talking to you.
I do too. I'm happy to join. During this whole pandemic, we've been those meme sharers. That's how we've gotten through. And I'm sure a little bit of microdosing and something else.
Awesome.
This ain't easy for us either. Oh my gosh.
No, it's not. Yeah.
It's not easy.
Therapists are made out of people too.
That's right.
And thank you for doing this with me, because my other passion is ranked choice voting, and I'm working on that for Colorado, and we're doing a lot of webinars for that. And we've discovered that when you have a conversation between two people, those presentations go a lot smoother than just one person. Like, wow, it's me talking for an hour and a half. So I was like, I need to get someone really fun to talk to, and Dr. Ebos got tricked into it. So thank you.
It wasn't a trick. It's a pleasure.
All right. Well, thank you for joining, everybody, and see you next week.
Bye. Thank you.
Bye.